during Ramadan. اتفضلي يا دكتورة إيناس.
Thank you very much, Professor Hisham, and I'm going to give an overview on Ramadan fasting, and then I'm going to finish with the oral treatment during Ramadan. بسم الله الرحمن الرحيم. شهر رمضان الذي أنزل فيه القرآن هدى للناس وبينات من الهدى والفرقان فمن شهد منكم الشهر فليصمه. This is an order from mighty God to fast during Ramadan. And we did a study in 2018, AASD fasting and diabetes study among Egyptians, type 2 diabetic patients, and we found that 98% of these patients intend to fast. Patients who completed Ramadan fasting were 79% of the patients, and those who could fast more than 20 days were 12% of the group. During the DAR 2020, we had 820 patients from Egypt. Actually, most of them were from our center in Cairo. And the mean age of these patients was 53 years. And the average hemoglobin A1C was 8.5%. And duration of diabetes of a mean of 9 years. And these were some results when comparing Egyptian group to the Turkish group. And for Egyptian type 2 diabetic patients who intend to fast during the year 2020, we found 92.9%, 93% of the Egyptian type 2 diabetic patients intend to fast. And another question, did the COVID-19 epidemic affect the decision of fasting or not? And we found that 92% of the patients, the epidemic of COVID did not affect the decision of fasting. They fasted in spite of the exposure to COVID. How many days did you manage to fast during Ramadan? And we found that Egyptian type 2 diabetic patients could fast 28 days during Ramadan 2020. And did they broke the fast due to hypoglycemia or not? We found that 36% of the patients suffered from hypoglycemia and they did not have to break the fast. During the fasting hours, just before iftar, there is the lowest blood glucose just before iftar, but just after iftar, the blood glucose is the highest. And these are the complications of fastings and risks of fasting: diabetic ketoacidosis, hypoglycemia, hyperglycemia, dehydration, and thrombosis. And during Crete study, the number of hypoglycemic events before Ramadan were 178 in this group of population, 1,885 diabetic type 2 patients. And this number of hypoglycemic events of 175 hypoglycemic event was increased to 285 hypoglycemic events during Ramadan months. This is the DAR global survey, and I was honored to be one of the authors. And this was studying older adults with type 2 diabetes who fasted during the COVID pandemic. And we found that the highest incidence of hypoglycemia was between 3 p.m. and Maghrib. So this is the risky time during the fasting hours. And for patients who broke the fast due to hypoglycemia, only 31% of the cases broke the fast due to hypoglycemia. This is a study we did, and Professor Hisham just mentioned about the pre-Ramadan education and the benefit of pre-Ramadan education and improvement in hypoglycemic events and management of hypoglycemic events with patients receiving pre-Ramadan education. Another two posters were published in IGF Busan 2019 about the effect and the benefit of pre-Ramadan education on people with type 2 diabetes, and also there was a great benefit of pre-Ramadan education on people who intend to fast Ramadan. And this is our fatwa taken by Fadilat al-Mufti. This fatwa is dedicated to the Arabic Association for the Study of Diabetes and Metabolism in 2012. And let me mention the important word in the fatwa. فإن غلب على ظن المريض أنه إن صام حصلت له مشقة أو صام ثم حصلت له المشقة سواء باشتداد وطأة المرض عليه أم احتاج إلى تناول الدواء أم غلبه الجوع أو العطش، وهذا هو حال غالب مرضى السكر، جاز له أن يفطر، بل ويجب عليه أن يفطر إذا خشى على نفسه من الهلاك، لقوله تعالى ولا تقتلوا أنفسكم إن الله كان بكم رحيما، وقوله تعالى ولا تلقوا بأيديكم إلى التهلكة. الفتوى دي كانت مقدمة مننا لدار الإفتاء، والحقيقة أمانة الفتوى برئاسة الدكتور محمد وسام خضر وفضيلة دكتور مجدي محمد عاشور مستشار فضيلة المفتي ادونا الفتوى دي، كانوا معانا ندوات وعشان نقدر نفيد مرضى السكر ونمنع عنهم الضرر. We all know DAR guidelines, and I'm part of DAR guidelines, and I appreciate a lot efforts done by DAR guidelines. But the AASD did a consensus in 2021 because there is some social and environmental factors in Egyptians who intend to fast. And this is a summary of the AASD consensus 2021, and we're going this year to make some changes in this consensus, some update. But let me here discuss some topics that we have pregnant diabetic ladies among the very high risk patients. And maybe there is no time to read all the groups, the very high risk, the high risk, the moderate risk, and low risk. But we can find this consensus in your groups on WhatsApp, and you're going to find it distributed by some pharma companies in Egypt. Therefore, hypoglycemia is a great risk in Ramadan, and this must be considered in selecting the proper medication. And let me start with lifestyle, because we had many questions on lifestyle today in the session. And usually fasting diabetics start to break the fast on dates, and we may tell the patient to take just one date or 3 dates at maximum, because the caloric equivalent in one date is around 70 kilocalorie. And then the patient may drink some hot drink and then go to Maghrib prayer. And this is the dining table in an Egyptian house, Egyptian iftar, classic Egyptian iftar in maybe high standard family, and followed by dessert. But these are the example for an average breakfast. ده مثال للإفطار. حضراتكم كلكم سألتوا. بنقول بعد أذان المغرب مباشرة تناول تمرة واحدة، ثم طبق الشوربة. طبق الشوربة بيبقى أنواع من اللي موجودة هنا: شوربة طماطم، لسان عصفور، شعرية، بصل، فراخ، مشروم. تجنب إضافة الكريمة والدقيق والدسم للشوربة. الخضروات، طبق خضار كبير، يفضل الابتعاد عن البطاطس والبسلة. طبق سلطة كبير بدون إضافة زيت. النشويات نوع واحد من التالي: رغيف خبز بلدي أو 8 ملاعق قرص، 8 ملاعق مكرونة، 2 ثمرة بطاطس صغيرة، أو كل ده أو على فكرة مسلوقة أو مطبوخة، 2 محشي فلفل، أو 4 محشي كوسة أو باذنجان. الحقيقة لازم الدايت يبقى مناسب للناس كلها، ولازم يبقى فيه الحاجات اللي الناس بتحبها عشان الناس ترضى to follow this diet. بالنسبة للبروتينز، طبق فول. بعض الناس طبعا بتفطر فول، مش بتاكل لحمة أو فراخ، فلازم نديها التشويس ده. أو طبق بصارة، أو ربع فرخة، أو ربع أرنب صغير، أو 150 جرام لحوم أو سمك. تناول اللحوم بيكون مسلوق أو مشوي. المشروبات: كوب من التالي: كركديه محلى ببدائل السكر أو مياه غازية دايت، أو عصير جوافة بقليل من اللبن محلى ببدائل السكر، أو 8 وحدات فراولة عصير ومحلى ببدائل السكر. يعني لازم ندي البيشنت بتاعنا تشويس ازاي يقدر يعمل المشروب بتاعه من غير هاي كالوري. خلونا نقول ان the popular قمر الدين بقى اللي هو المشهور قوي الناس كلها بتحبه في رمضان، بنقول لهم ان كوباية قمر الدين فيها 500 سعر حراري، وده طبعا قمة الخطورة. بنروح نصلي التراويح، بنكون في الحالة دي قللنا البلاد جلوكوز اللي هو هايست افتر افطار، وبعدين بناخد نوع واحد من التالي اللي هو ممكن يكون فواكه أو حلويات. الفاكهة طبق سلطة فواكه أو أي أنواع فواكه غير سكرية، أو 2 وحدة قطايف. يعني دايما الواحد يقول لمرضى السكر ان هم يعني الحاجة اللي موجودة في البيت والحاجة اللي موجودة في رمضان لازم يدوق منها عشان بس يقدر يتبع النصايح بتاعت حضراتكم. او ياخد خشاف. الخشاف ده بنقول له واحدة ثمرة من كل نوع: واحدة بلح، واحدة مشمش، واحدة قراصية، ومعاها فول سوداني او مكسرات. او ان هو ياخد فاكهه بقى: تفاح، برتقان، جوافه، موز، شمام، بطيخ، خوخ، وهكذا. بالنسبه لوجبه السحور، بنؤكد على الكلام اللي اتقال قبل كده ان هي تكون قبل الفجر مباشره. بيبقى فيه رغيف بلدي على الاقل، يعني دايما يكون فيه اهتمام بالنشويات في وجبه السحور، او 2 سن، 4 معلقة فول. ممكن طبعا لو هو شهيته أكتر ممكن نزود له الفول، ولكن مع كمية صغيرة من الدسم اللي هو معلقة صغيرة زيت أو معلقة صغيرة سمنة بلدي. طبعا الزيت أفضل أكيد من السمنة. 1 علبة زبادي أو كوباية لبن نصف دسم، قطعة جبن أبيض أو رومي أو قريش أو فلامنك، فاكهة نوع واحد من التالي. ده مثال لفطار مريض سكر. Individualization of treatment is the key to management of diabetes during Ramadan. Before Ramadan, we should do an assessment and categorize the risk, create individualized management plan. During Ramadan, nutritional plan, medication adjustment, and to advise the patient to do an SMBG daily. And the frequency of SMBG is according to the type of treatment given to the patient, whether non-hypoglycemic medication or sulfonylurea or insulin. After Ramadan, there is post-Ramadan follow-up to discuss the medication and regime readjustment. And for oral antidiabetic medications, metformin, it is safe to use metformin during Ramadan. There is no randomized control trial conducted on metformin monotherapy during fasting with diabetics. However, the risk of hypoglycemia is low for metformin. So fasting is considered safe with the use of metformin. These are the changes on metformin dosing during Ramadan. If the patient is taking one daily dose of metformin, there is no dose modification and to be taken at iftar. If the patient is taking twice daily dose, no dose modification is required and the dose to be taken iftar and sahur. For patients on 3 times daily dosing, we take 2/3 of the dose with iftar and 1/3 of the dose with sahur. For prolonged release metformin, we prefer to give it on iftar. For sulfonylurea, during Ramadan, if the sulfonylurea is given once daily dosing to be taken with iftar, and in patients with well-controlled blood glucose level, we may reduce the dose of sulfonylurea. For patients on twice daily dosing, iftar dose remains the same, and for controlled patients, for well-controlled patients, we may reduce the sahur dose. Older sulfonylureas like glibenclamide carry a risk of hypoglycemia and should be avoided. And the second generation sulfonylurea glycoside, especially glycoside MR and glimepiride, should be used instead of glibenclamide. This is the risk of hypoglycemia, which is less with second generation sulfonylurea when compared to glibenclamide. Glitazones during Ramadan, pioglitazone is the only TZD approved for use of type 2 diabetes now, but there is limited clinical data on its use during Ramadan, but it's safe. It does not require dose modification during Ramadan and can be taken with sahur or with iftar. For SGLT2 inhibitors, there should be some caution, especially in older individuals, due to the risk of dehydration, but there is no dose adjustment required during Ramadan, and it's advised to take the dose with iftar. Please don't start SGLT2 inhibitors just before Ramadan. We may start treatment with SGLT2 inhibitors 2 to 4 weeks before Ramadan to avoid any dehydration, thirst, or polyuria. For DPP4 inhibitors, we don't require any treatment modification during Ramadan, and they are safe as regards hypoglycemia. And these are the benefits of DPP4 inhibitors, vildagliptin, sitagliptin, and other DPP4 inhibitors during Ramadan, that they carry low risk of hypoglycemia while maintaining good glycemic control, and beside the other benefits of DPP4 inhibitors. This is the summary of all oral antidiabetic medication, just in one slide. And let me add here the GLP-1 receptor agonist, because there was 2 questions about GLP-1 receptor agonist. Once appropriate dose titration has been achieved, no further dose modification is required. So if we are reaching the dose of GLP-1 receptor agonist before Ramadan, please don't increase the dose during Ramadan, and maintain the same dose during Ramadan, whether once daily or once weekly. For short-acting insulin secretagogues, If it's taken 3 times per day and the patient is not well controlled, we can take 2/3 of the dose with iftar and 1/3 of the dose with suhoor. If the patient is very well controlled, we may reduce the dose to just 1/3 before iftar and 1/3 before suhoor. This is a case scenario, and I'm going to discuss it with you. So please, I'm expecting your comments. Mrs. Noha is a 54 years old female patient diagnosed with type 2 diabetes 3 years ago on metformin 2000 milligram per day, ripaglinite 0.5 once daily before the main meal, together with lifestyle in most of the days. Some days she had to reduce the dose of metformin because of sense of bloating, and sometimes she had to stop it for a few days. She had history of recurrent UTI. She came for follow-up and advice before fasting Ramadan. يبقى Mrs. Noha on metformin and ripaglinite once per day. And she's having some GIT upset due to metformin and history of recurrent UTI, and she's coming for pre-Ramadan advice. Her hemoglobin A1C 7.8, so she's not controlled yet. Fasting blood glucose 160, 2 hours postprandial 240, TSH normal, estimated GFR 50, albumin creatinine 30 milligram, lipid profile normal, hemoglobin 10.2, urine analysis pus cells 30 to 40. She's having UTI, blood pressure 140/85 with no postural changes, BMI 32, chest heart normal, abdominal examination scar of cesarean section, upper limb mild pallor, she's having anemia, and lower limb absent dorsalis pedis on the right side, no signs of ischemic changes or atrophy. She made some investigation to her lower limb. This patient, what's your decision to fast or not to fast? What is the risk for her, and how to minimize her risk if she wants to fast Ramadan? I'm going to expect your input and comments on this case. And these are the questions now to be discussed. What's your hemoglobin A1C target for this patient? Less than 6.5, 6.5 to 7%, 7 to 7.5%, from 7.5 to 8%. And how to choose an oral anti-diabetic medication for this lady. Are you going to choose a sulfonylurea, thiazolidinedione, dipeptidyl peptidase inhibitor, SGLT2 inhibitor, GLP-1 receptor agonist, and let me remind you that she is taking already metformin. Let this lady take the reward of fasting, and let me finish my presentation with the virtue trial. Really, I had the pleasure to be part of the virtue trial, published in many places, sponsored by Novartis, and it was a multinational, non-interventional study to assess the effect of vildagliptin relative to sulfonylurea as dual therapy with metformin, or as monotherapy in Muslim patients with type 2 diabetic patients fasting during Ramadan. And the results of the virtue study, significant lower or fewer patients experiencing hypoglycemia with vildagliptin versus sulfonylurea during Ramadan. And this is a percentage of patients having at least more than one hypoglycemic events in vildagliptin versus sulfonylurea. The sulfonylurea is in the black. And for patients with grade 2 hypoglycemic events, there was no severe hypoglycemia with vildagliptin versus sulfonylurea. There was 3.5 folds less hypoglycemic events in vildagliptin versus sulfonylurea. رمضان كريم، تقبل الله منا ومنكم صالح الأعمال. شكرا لحضرتك.
Thank you, Dr. Inass. Dr. Inass discussed many of the practical problems we are seeing in Ramadan. Now open discussion for questions first and then discussion about the scenario Dr. Inass gave us. نبدأ بالquestions دكتورة إيناس الأول؟
في أسئلة؟ لسه
ما فيش أسئلة.
هو بينقلها
حضرتك عايزة تقولي لنا حاجة على البريجننسي؟
الحقيقة عايزة أقول لكم لو في وقت، مش عارفة دكتور عمرو أتكلم على البريجننسي ولا إيه رأيك دكتور عمرو؟ دكتور عمرو لسه مش معانا.
في سؤال دكتورة إيناس، في سؤال وصل أهو.
أنا ممكن أقول لكم البريجننسي بسرعة لأنه موضوع مهم قوي قبل ما تيجي الأسئلة. This is the case scenario of two pregnant ladies, fasting of the pregnant diabetic lady, two cases. Mrs. Mona, 28 years old, type 1 diabetic since 4 years. Now she's pregnant in her third month of pregnancy, and she wished to fast next Ramadan. And Mrs. Noha, 36 years old, discovered to have gestational diabetes during the 5th month of pregnancy, and she wished to fast next Ramadan. Diabetic ladies with pregnancy need tight glycemic control with basal bolus insulin. And these are the targets for blood glucose level: fasting blood glucose of less than 95 milligram and 1 hour postprandial less than 140 milligram and 2 hours postprandial less than 120 milligram. Two tight numbers to be achieved without incidence of hypoglycemia. These are the Canadian diabetes guidelines, and these are the guidelines of the American Association of Clinical Endocrinology and the American Diabetes Association guidelines. For patients with gestational diabetes, the preprandial to be less than 95, and for patients with pre-existing type 1 or type 2 diabetes, the preprandial and bedtime to be between 60 and 99. Actually, this is impossible to achieve. And for postprandial with gestational diabetes, 1 hour less than 140 and 2 hours less than 120. And for pre-existing diabetes, peak postprandial to be between 100 and 129, and hemoglobin A1C equals or less than 6.6%. These targets are impossible to be achieved except with insulin pump, actually. And if the patient is not using an insulin pump, this patient is at risk of repeated hypoglycemia. And let me show you these side effects and complications of pregnancy with diabetes. Pregnancy itself may be associated with impaired counter-regulatory mechanism and hypoglycemia unawareness. And the risk of hypoglycemia in diabetic pregnancy is due to high insulin concentration and failure in physiological protective mechanism. 45 to 71% of type 1 diabetic women experience severe hypoglycemia during pregnancy, and severe hypoglycemia can occur during pregnancy 3 to 5 times more frequently in the first trimester, and the effect of hypoglycemia on the fetus is controversial. Maybe our possibility of teratogenicity is still debated, and low level of maternal glucose during pregnancy may cause fetal growth retardation and small for gestational age infants. Maternal hypoglycemia may also determine impaired fetal beta cell function, and subsequently diabetes when the baby is becoming maybe adult. These are some other groups of complications in pregnancy: placental insufficiency with hypoglycemia, diabetic ketoacidosis may be fatal to the fetus, neonatal hypoglycemia, very high incidence rate of severe hypoglycemia between 19 to 44% reported in diabetic pregnancy, and a 2008 study on pregnant ladies with type 1 diabetes found that 45% experienced episodes of hypoglycemia, especially during the first and second trimester. So these are the complications of fasting with pregnancy. So would you allow your patient to fast if she's pregnant diabetic lady or not? I will not, really. وبعدين ربنا سبحانه وتعالى رحيم، ربنا أعلم مننا وقال إن الحامل غير مصابة بالسكر تفطر. إحنا مش معقول نقول للحامل المصاب